And welcome to the show, everybody. I'm of course your host, Joe Basha, and I am welcoming you to the final program of the Corona 30 series. So it's Corona 30 Part 3, Day 5. So we have had quite an experience thus far, bringing you 15 straight days, I guess 3 weeks, 15 days and 3 weeks, Monday through Friday of programming. So before I get started, let me go straight to our sponsors and my housekeeping notes that I have to do. LivaNova and Siemens, great partners, really appreciate their support. They've been very helpful to us, and we want to thank them. Social media, make sure that you like us, follow us, and share us on Facebook, Twitter, and LinkedIn, and also hit the subscribe button and the thumbs up and the bell notification on YouTube. We really need to keep bumping those subscribers up. It's really making a difference for us. Check out our websites, perfweb.us and perfusioneducation.com. You can check all of our content out. You can look at our structure. You can see what kind of services we're able to provide. All of those are going to be being expanded upon as time moves on. And also, of course, you can want to join our faculty, or you want to reach out to me, you can contact us or email me at contact@perfusioneducation.com. You should see it right there, at the bottom of the screen, and do that. So without further ado, I would like to, oh yeah, and we're going to call in early. Okay, we're going to open the phone lines when you see this number, this symbol, and we're going to open the phone lines now. So the phone lines are open right from Jump Street. The theme of today's program is, basically, what have we learned in the past 30 days? This whole situation has affected so many things, and frankly, it would be impossible for me to really go through all of the things that this has affected, but it has certainly affected me and some of my colleagues whom I know very well. Even those I don't know that well, but just know and talk with, has affected our ability to deliver perfusion services. It has really had a major impact, more so in some places than others, but I think over time there is going to be a new normal. I don't know that I like it, but I do think there will be a new normal. I'd like to go back to how we were. But there is an advantage, I think, in dealing with this COVID crisis, in that I think we will reduce the spread of other commonly communicable diseases as well. So I think we will see stuff like our influenzas go down and colds and things like that. I think you're going to see a reduction in those things. Now, will it last for indefinitely? I don't know, but certainly in my view, the foreseeable future is going to be very different. I wasn't going to give a presentation today, but I decided I was going to. Now, in the past, it's just very short, and it's about a new problem that is emerging with these young pediatric, these children, both in England and the UK, New York, and in Philadelphia. And I'll get into that here in just a second. But before I get started, I want to tell y'all, first of all, that I am so humbled and I'm so grateful for all of your support, all of your participation. I have really had an incredibly rewarding experience doing this Corona 30 series. Now, look, I told you, 15 programs in 3 weeks. I have created a dozen or more presentations. My good friend John Ingram from Florida, who is on this program a lot, has created a bunch of presentations for this series, and I really think it brought a lot of value. I mean, meetings are canceled. People could apply to the board and request a postponement, but all of that was on a case-by-case basis. That was going to overwhelm the board if they got a whole bunch of those requests. And so we already had this platform and decided to do this. Hopefully it brought benefit to you, our colleagues, but along with bringing that benefit to you, this has been personally very rewarding for me. We have been able to accomplish something that seemed, when we first thought of it, insurmountable. And I feel like we've done it in a way that doesn't appear disjointed or thrown together. It's well thought out. It's been planned. It has been, now some of it has, had to fly by the seat of our pants a little bit, but I really feel that we were able to produce educational material that had real value, that you could use by bringing in some incredibly good speakers, that you could use in your practices with real world information, had some great dialogue, like I said, incredible faculty members, very smart people, and did it in a way that comports with our level of professionalism. So, we had some hiccups. We had the program drop off a few times where we blew our box up, and there's always going to be something is going to happen, or somebody's internet connection wasn't great, or their lighting wasn't great, whatever it was. I mean, we did have little hiccups along the way, but we've learned from those too, and we've gotten better. And I don't think there's anything that is out there for perfusion education, nursing education, and I don't even think for physician level education, to be frank with you, that comes even close to matching the quality and the pleasantness, if you will, of this experience. It's very high level, it's important information, it's serious. This isn't a joke. Even though we have fun, we make fun a little bit, but that's the atmosphere that I want. I want it to be a welcoming atmosphere. But this is serious business, but it doesn't have to be boring. It doesn't have to be bland. It doesn't have to be sterile. It doesn't have to have, to look like it's put together, from a junior high school science project. We really spent a lot of time to try and bring you something that is commensurate, that matches your expectations and your professionalism and what you expect. You expect something to be, you're paying for it, even though our stuff is aired for free, but which is the way we want it, it's free for everybody to learn. But if you need those CEU certificates, you're a member of this, and we want you to be proud of what it is you're a member of. So hopefully we've met those expectations. However, and with that said, since I do like to have fun every once in a while, I found a video, because this is the last PowerPoint presentation I had to do, even though it's only 5 slides, but I've done a lot. And I want to show you how I would have felt today if we had done the Corona 40 and I knew I had to do another program on Monday.
I haven't closed my eyes in 3 days. I've only eaten a chicken leg and some clear broth since Wednesday. Yes, I'm cracking up. I'm coming apart at the seams. Look at my eye. I used to have a perfectly good eye. I had 2 eyes, I mean.
That's about where I think I would have been. And if you don't know where that movie comes from, it's Peter Sellers in I believe it's The Revenge of the Pink Panther. Or Return to the Pink Panther. I think it was Revenge of the Pink Panther, but it was a great series, Peter Sellers, and that was former Chief Inspector Dreyfus, who was Peter Sellers, was Clouseau and his nemesis. Great movie, you should watch it. So I wanted to talk to you about something, because a good friend of mine, Praveen, who's been on this program before, we did that COVID-19 update from Mount Sinai Hospital in New York. He was telling me about some patients, these pediatric patients that they're seeing. And so I wanted to go over this with you. Did you want to go ahead and throw the slides up, or are you ready to do that? Yeah, we're going to go ahead and go with the slides, yeah. I'll do that now. Thanks. And they'll go ahead and click the button there. Okay, good. Okay, so there we are. So, and I went and did some exploring on this, and I got somewhat of an update on it. So this novel inflammatory syndrome they're seeing in children, possibly linked to COVID-19, I think this is a big issue that I think we need to be keeping an eye on. Now, right now, the numbers are very, very low, but let's talk about what they are seeing if we can. The symptoms are sort of atypical Kawasaki disease or toxic shock syndrome. They have fever, they have a red rash, abdominal pain, vomiting, diarrhea. Interestingly enough, though, less than 50%, and it's actually less than 40%, had any respiratory symptoms at all. Now, the clinical presentation is persistent fever, rash, conjunctivitis is very common with this, peripheral edema, extremity pain, and GI symptoms. In the 11 patients from the UK, they developed a warm vasoplegic shock syndrome that was not responsive to volume. Now keep in mind, they don't know that this is COVID-19 or affiliated with COVID-19 in any way, but this is novel and something they're not used to seeing. So, you know, there's kind of an association. We have this coronavirus going on and now we have this. But it's unresponsive to volume. They did require, all of the patients, levo and milrinone. 7 of them required ventilatory support for cardiovascular stabilization, and this was despite not having respiratory symptoms, which was very interesting and concerning. The syndrome progressed with small pleural and pericardial effusions, mild ascites, elevated CRP, C-reactive protein, that, ferritin, and D dimers. 1 child developed refractory shock and required ECMO, and 1 died from a large, which is that patient, died from a large cerebrovascular infarct. All tested negative for the active virus SARS-CoV-2. In a second wave of 20 that have now been in the ICU, and this is in New York, this is in Massachusetts, and this is in New York and Massachusetts, have seen similar clinical presentations, and 10 of those 20 are SARS-CoV-2 antibody positive. Yeah, so that's the last slide. So this is something new, and this is all we know. This is all I know, and what I was able to discern or ascertain from the Medscape news that exists. And my friend Praveen says that they are seeing these patients. It'll be interesting to see how this all plays out, but the belief is that it is a post-infection abnormal immune response. So, you know, is it related to the COVID? Again, the numbers are very, very low. It's right now very rare. They're not having any kind of outbreak, if you will, but it's something we better keep an eye on, because especially for our pediatric colleagues, but if this is affecting younger people, does an 11-year-old go to a pediatric hospital, or they just show up in the ER of a regular hospital? So my adult perfusionist may be confronted with an 11-year-old or 12-year-old or a 13-year-old. Certainly if it's a baby, it's going to go to the children's hospital, and should, or somebody who is competent with a pediatric or neonatal ECMO unit. That's something that's very important. But keep your eyes open for this, and let's see what happens with it. But it concerns me. As we did these programs, and we got into this COVID thing, of course, first, I had already started with the online education, recognizing that there was a need, there was a void. But COVID, from the time that occurred and all of the travel restrictions and all of the meetings got canceled, we have seen our membership grow tremendously. So we're seeing, a lot of people, probably a 300 to 500% jump in the number of people using our resource to get their CEUs. And of course, we're getting close to the end of the reporting cycle, so that number typically does go up anyway. I saw that when I did conferences, but we're seeing it again play out in this. And I think that we were just in the right place at the right time with the right tool when all of this happened. So we did start this over a year and a half ago, almost 2 years ago. And I'm glad we were here when this happened, because it certainly has helped us to gain a broader audience. And again, without an audience, we don't have a show. I mean, that's the bottom line, right? Healthcare professionals, and how has this helped us with delivering services? Well, healthcare professionals with child care responsibilities. Let's consider them. Let's look at that. How many single parents, moms or dads, exist? How many parents that maybe the household is still completely intact? Mom and dad are at home. You have kids that are in school. Maybe you have 2 or 3 kids. Both people are in healthcare. Maybe both are perfusionists. And all of this is happening. Or maybe they're in a different profession altogether. But the problem is daycare went away. Childcare schools shut down. Now the kids have nowhere to go, but the parents may be on call. Well, now what do? How are you going to cover call? How are you going to deal with emergencies? How are you going to deal, because as a business, because we have 2 parts to us, and I keep them very separated for good reason. We want to always maintain our independence as an educational platform. But you know, I do run a perfusion service company, and as such, you know, when all of this happened, we went into everybody is on call, meeting, you know, travel is canceled, and I'll get a little more into that because that's sort of evolved. It didn't all happen at one time, but no days off, all hands on deck, because we had no idea what was really going to happen. As it turns out, for us here in Texas, it didn't really turn out that bad. It wasn't horrible. But regardless of that, it was still a stress for everybody because they had to be available. If they have children, what are they going to do with them? How are they going to manage that? What if they have elderly parents that need to be taken care of? But yet they have this responsibility. I'm on call. I cannot go anywhere. I have to be available to leave at any moment. And that is our profession. That's, whether you like it or not, that is a reality of our profession. So healthcare professionals with child care responsibilities, I think, showed me a lot of deficiencies that we have as a system. And then you get into the issue of employee job responsibilities versus employer responsibilities. So as a service provider, I had to be concerned about, we have obligations to these hospitals. They're expecting that obligation will be met, so they're going to accept patients for whatever the case may be, whether it be heart surgery or whether it be ECMO or whatever it might be. But we also have, including myself, 3 very at-risk patient populations, just by virtue of our ages. Now, not necessarily the comorbidities, but our ages. Our ages put us in a much higher category for having a bad outcome associated with getting this disease, with COVID-19. And so we had to balance that, because I don't want to send my staff into a hospital where they may get infected and then die, because that's not good for business either. Losing staff is not good. But at the same time, there's no company, no hospital, no service, no industry, it doesn't matter what it is, has unlimited personnel assets. There's just not a secret door that you open up and you have perfusionists or autotransfusionists or whomever it may be hanging on the rack that you can just bring around and pull off and say, okay, you're going to go there. Not to mention, doesn't matter how many people you have, if they're not licensed in that state, in proximity to it, because travel was banned without some good cause. Now that would probably meet good cause. Then you have credentialing. Then you have, what about their own personal situation? What if they get sick while they're traveling? This was a very stressful event, albeit it didn't turn out that bad for us. We were nothing like New York, nothing at all, which I'm grateful for. However, Had we gotten like New York, had that happened, I can tell you that I'm pretty sure we would have been overwhelmed very quickly. I learned a lot about what we aren't able to do more than I learned what we can do, which are lessons that I really have to take and analyze and figure out, what am I going to do the next time something like this occurs. We had to make decisions about furloughing or not furloughing, because what happened to us, in contrast to what happened in New York, what happened to us, or New York City more specifically, really, what happened to us was our caseload, because they shut it down, no elective cases. Our caseload went to nothing. I mean nothing. And as an organization, and perfusionists are not inexpensive, we all know that. Do we start furloughing? Do we tell people to take mandatory vacation? Well, how can you do that if you're saying we need all hands on deck because we don't know what's going to happen? And I think that's what really got us, is there wasn't a flood of these patients to where it was like just bedlam and chaos and just having to just deal with one patient after another at a time. It was this constant uncertainty of what is going to happen tomorrow. Is this going to be a flood coming, or is it going to stay like this? We're not doing any elective cases to keep every operating room available for ICU overflow. And listen, I know somebody in Nashville that took an entire floor of a humongous parking garage and built it out to an ICU. Never had one patient in it that I'm aware of. But if you didn't do that, and then you did get the flood, then what were you going to do? And I think that also brings up some issues of, like I said, do we start furloughing people, or do we just keep going the way we're going? I mean, we have no revenue coming in. We got to pay people. Of course, the government PPP definitely helped. There was no question about that. That saved us from an economic perspective. But it's contradictory, And this is something that's always bothered me in my life. And I've been around a long time. I've done everything. I've been a perfusionist for a hospital employee. I've worked for private perfusion groups. I've worked for smaller. I've worked for big corporation perfusion groups. I've worked for surgical groups. I've run my own business where I was the kind of eat what you kill sort of thing, sole provider, sole independent practice. Did the traveling thing a little bit. So I've run kind of the gamut of all of these different ways that we can deliver perfusion services. But the thing that's bothered me through my lifetime has been when I've seen hospitals, when they're slow, they have low census, and they start calling people off. And you can choose to take your vacation and get paid, or you can choose to take the day off without pay, one or the other, but it's mandatory. You get, and they do it on a rotation, and it's just an accepted practice. But then when it's super busy, they will require you, and I see this more in nursing service, but I've seen it in perfusion too, require you to stay. You don't have a choice. And I've always felt that was unfair. So as an organization, we made a conscious decision to say, if we're going to tell people that your vacations are canceled, you cannot go anywhere, even though travel was highly not recommended, and you have to be on call and available at the drop of a hat, 24/7, no days off, until this is over, and we say, we're opening it back up again, then I think doing anything other than keeping them whole would have been a terrible thing to do, and something that I was not supportive of. And as an organization, we didn't do that. We were able to keep our entire company, from the most senior perfusionist, senior autotransfusionist, and their staffs, all the way to our office staff and everything in between. We made 0 changes because it would have been unfair. But what did we do? Because people are sitting around. We still don't know if the flood is coming, but right now it's not, and time is passing, and it doesn't seem like we're going to have a flood, and you start getting a handle on what's going to really happen here. So we started giving them projects to do, and they did some incredible work, things that really needed to be done. Our carts in the hospitals, we tried to limit travel to hospitals, but our carts in the hospitals, the condition of the pumps, our inventory, because we provide supplies. They got their bios done for our new website, which we're going to be launching here pretty soon. Right, David? Yeah. Website's coming, brand new website for our company. I'm really proud of it. And I think you'll really enjoy it too. We're working on an app. We're doing these programs, educational programs. I know you've seen Tammy here. You saw Mike Brown. You saw Patrick O'Toole. You saw Min Tran. You saw Nate Badair. You've seen Stephanie Ebus. You saw Rodell Ebus. So you've seen people. And we made good use of people's time that they had, and not just sitting around sheltering in place with not knowing what's going to happen. It gave them something to do, which gave them a sense of security that things are going to work out okay. I think sometimes people consider perfusionists, or sometimes even higher, well, let's just say the higher paid allied health medical professionals that exist in this world, that somehow they can absorb a lot more financially. And it's just not true. None of us are rich. Well, maybe a few are, but most of us aren't. And it's just human nature. People live to their means. We don't know what people's responsibilities are, if they're helping their parents, if they're helping their kids, and all of this kind of stuff. Older kids, maybe they have. So to assume that this didn't affect those people, or that sitting home sheltering in place is not going to have a psychological impact on them. And what about all the rest of the people? I talk about us as healthcare professionals. I talk about how we deliver perfusion services. We had to be ready. You got to keep your staff safe. I think there were good mechanisms in place to do that. The N95 masks that the hospitals had, the PAPR suits that the hospitals had. I mean, they didn't want their staff getting sick or hurt either. So I think everybody did a really good job at protecting the health of the healthcare professionals that had to go to work, at least here in our area. Here in the greater Houston area, I know we did that. I think that we did an exceptional job, and I think we would have been able to handle a lot. But based on what I know, what I saw from New York, had we matched that, I don't think there is anywhere in the country, and I really believe this, and I think this is a national, probably international problem, really. I don't think there's anywhere in the world who is truly prepared for something like this, where you have an overwhelming number of people coming in with severe respiratory distress, needing to be on the vent, possibly needing to go on ECMO. There aren't enough platforms. There aren't enough people to know how to run them. And there's way more hospitals that don't have ECMO than there are that do have ECMO. So if you started doing transfers, the ECMO centers, those hospitals that have it, would have been overwhelmed so rapidly. And so we're not prepared. I mean, really, bottom line is we are not prepared. Now, we did a great job. I think New York did a fantastic job with what they had. I think that everyone worked together very well. But if you remember, this all started in Washington State. And Washington State did not get nearly as bad as what everybody thought it was going to, and New York blew up. And I still have not figured that out. Of course, New Orleans had Mardi Gras, so it's not surprising. They fell apart. Okay, so, I think we did a good job in terms of having the staff, and every single little department would have to do this so that you had a big collection. I think we made good decisions about stopping the no time off, basically putting everybody on full call, keeping every employee whole when things started slowing down, because I think that shows the commitment that we're willing to give back. And I think more hospitals, more companies that did that will pay dividends in the long run, because that's an important feature, I think, that cannot be understated. We got that from our employees because they were committed to our patients, which is what our business is based upon. When we realized it wasn't going to be bad, keeping those people whole was a critically important thing to do, because that's how you have the proverbial, if you will, two-way street, right? So that's that on that. Our caseloads did evaporate, as I told you. It was very, very painful. But I want to talk about something else, which I think fascinates me. I understand, listening to the various information channels that I listen to and resources that I read, that cancer diagnoses have dropped precipitously. I don't think COVID-19 cures cancer, and that's something that I'm worried about. When you talk about STEMIs and ACS, time door to balloon is critical to saving muscle, but our cath lab volume of STEMI and non-STEMI and ACS have dropped incredibly. Where are those patients? Well, I mean, I can kind of tell you. What about grandma with her broken hip? Because that's a very common thing to have happen. We didn't see a hip replacement for I don't know how long, and I find that to be incredible. Where did all those patients go? And it's something that really does concern me. Is I fear, and this is a prediction that I have, I fear that we will see, when the death toll, not percentages and all this kind of stuff, I'm talking about the death toll. I think when we get to that and analyze it, you will find that the death toll of patients that died from something other than COVID, a treatable disease that we would have normally been able to take care of quite easily, is going to exceed the death toll from the coronavirus. I truly do believe that, and it's going to be very interesting to see if that vets itself out, or that in fact is the data. I'm going to be watching that very closely, and really curious to see if that's what happens. You know, I will tell you about a patient that we recently took care of. And I know I've told you in the past from previous programs about the coronavirus patient that we did. And by the way, our next program, scheduled in June. It's June, right? Or is it June 11th? Yeah. Well, it's the 13th. Is going to be that first COVID-19 ECMO patient here in the state of Texas, which was here in the greater Houston area. And he's going to be here and talk about his story and how all of that happened. But we recently had another case of a patient who came in with COVID-like symptoms. And I think this is going to be something that's going to happen a lot now. And I'm worried about this too. And they were tested and they were negative. But nobody believed it was negative. They still believed that this person had it. So they tested again. That was also negative. So they tested again. In fact, they tested 5 times. 5. All 5 tests were negative. The patient overnight decompensated. Now this is over a course of a few days, because they got admitted, they got better, they got sent back home, then they came back. On the second admission, overnight, they went from talking and on some supplemental oxygen to full-blown code, needing intubation, lungs were stiff. There were major, major problems. And we had to rush and get that patient on VV ECMO and stabilize them, and then transported that patient to a different facility. Nevertheless, they tested the patient again. So 6 tests now, still negative. Now finally, looking at an alternate cause, it ended up being Wegener's granulomatosis, which is an inflammatory disease of the respiratory tract and blood vessels. It looked like COVID, but it wasn't COVID. The question that I have is, was that jump, if you will, to it's COVID. I don't believe the negative test, to another one. It's COVID. It looks like COVID. It has to be COVID. I think there's a lot of things that historically would have been identified sooner if you're not just looking through loops or a telescope and seeing just one little spot when there's all this other stuff out there. And so that's something that's concerning me as well, and something that we need to keep an eye on with these patients. Now, how we do cases, certainly there's going to be societal impact. They are opening some restaurants up and stuff like that. We're kind of getting back to our normal lives, and I'm going to be happy about that. But are we ever really going to get back to normal in the hospital, which is where we all work? Right now they're intubating the patient for surgery with no one in the room except for anesthesia. We're wearing masks everywhere we go in the hospital. It's going to affect turnover time, so the cases are going to take a little longer to get the next case in the room. And how will it affect staffing when the trigger for staying home now is so light? I've got a little fever, I don't feel good, things aren't right, I can't go to work. And you shouldn't go to work sick, I understand that. But there's a lot of reasons why you may not feel great, and it may not be infectious. You may not be infectious. It may not be something that you wouldn't ordinarily stay home from, but because of the very high high concern level, if you will, people are going to say, "Don't come to work. Don't go to work. Just stay home." Well, how do we manage staffing with that? What's that going to do to the balance that we have of supply, demand, cost, and revenue? We can't just hire enough people to account for all of these potential issues without passing that cost on to someone, the hospital. And then the hospital passes it on to the insurance company and to the patients. And then that gets passed on back to you in the form of your premiums or whatever, or taxes or whatever it may be. So this is going to have very far-reaching implications over the next, I would imagine, 5 to 6 years at least. Certainly a lot over the next year or two, but I think it's going to drag on for 5, 6 years, possibly even a decade. So that's all I got for you. This has been, again, a pleasure to talk to you about what we've been able to provide to you here with some great talks, from Dr. Simpkins and Praveen and John Ingram and Matt Warhoover and all the other folks, even me. We've had some, Dr. Garami called in. We've had some really good speakers. We've had some great presentations. We've had some great discussions back and forth. And we're wrapping up the Corona 30 and getting ready for our next schedule, our typical schedule that we usually do, one a month on a Thursday and a Saturday. We're probably going to try to do and add a little bit more as we go along. And I want to encourage you to please go to our websites, go and write me an email. And if you go look at our websites now and go to the resident faculty list, you will find a list that's pretty doggone impressive. And we want you on it too. You know, if you like to teach, if you're a content expert on something, or you enjoy sharing information, you have a case report you'd like to do, it doesn't matter to me what it is. If you have something that is of value for our colleagues to hear, that we can learn from, the experience, the knowledge, whatever it may be, anecdotes, it's all important. And every single one of us, every single practicing clinician has something that they can share, an experience they can share that can help somebody else, and usually a lot of people. So I truly encourage you to go to that website, contact@perfusioneducation.com, send us an email, let's get involved. I've got several people who have already sent us stuff. So you're gonna start seeing, again, some new faces, some new presentations, some new concepts. We're gonna try to keep it fresh, new, different topics, keep it pithy, keep it exciting, keep it inclusive, keep it fun, and make it better as time goes on. Again, thank you for allowing us into your homes and offices. Thank you for giving us this platform. Because we have an audience, we have a show. So I have to thank all of you and thank all of our incredible faculty that have been here up to this point, and even those who will be here in the future. So I will see you June 11th, I believe at 5 p.m., somewhere around there. It's on our station. You can take a look at our site and see what the date is, see what the topics are. It's already approved, I think, for 7.8 Category 1 CEU by the ABCP. We want to keep collaborating with other institutions. We're just going to really do a lot to keep making this the best platform. And right now, I think we are by far, but I want to be even better. I'm not settling for this. We're just going to keep going and making it better. And I want you guys to be a part of that growth. So thank you. We'll see you in June.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed Cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow DUO. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow DUO cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.